Welcome to Pediatric Case Review. Today we present a comprehensive clinical review of Alagille syndrome. This lecture is designed for healthcare professionals and will cover the genetics, clinical features, diagnostic approach, and management strategies for this rare multi-system disorder. We will use a case-based format with multiple choice questions to enhance your clinical reasoning skills. This evidence-based approach will provide you with practical knowledge to recognize and manage patients with Alagille syndrome effectively. Alagille syndrome is a rare autosomal dominant multi-system disorder with a prevalence of 1 in 30,000 to 50,000 live births. Today's lecture objectives include recognizing the clinical features, understanding the diagnostic approach, implementing management strategies, and appreciating the multidisciplinary team approach required for these complex patients. We will use a case-based multiple-choice question format to enhance your clinical reasoning skills and provide practical knowledge applicable to your practice. A 3-year-old child presents with jaundice and characteristic facial features. The parent reports having similar features since childhood but was never formally diagnosed. Which genetic mutation is most commonly associated with Alagille syndrome? Option A, JAG1. Option B, Notch2. Option C, ABCB4. Option D, ADP8B1. Consider the inheritance pattern and the most common genetic findings in this multi-system disorder. The correct answer is A, JAG1. 90 to 94% of Alagille syndrome cases are caused by mutations in the JAG1 gene, located on chromosome 20, which encodes the JAG1 protein that serves as a ligand for Notch receptors. Notch2 mutations account for only 1 to 2% of cases. ABCB4 and ADP8B1 are associated with progressive familial intrahepatic cholestasis types 3 and 1, respectively, not Alagille syndrome. The inheritance pattern is autosomal dominant with variable expressivity, and 30 to 50% of cases result from de novo mutations. The pathophysiology of Alagille syndrome involves disruption of the Notch signaling pathway, which is critical for cell fate determination and organ development. The JAG1 mutation affects multiple organ systems during embryonic development. In the liver, it leads to impaired bile duct development resulting in paucity of interlobular bile ducts. Cardiac development disruption causes pulmonary stenosis and septal defects. Skeletal manifestations include butterfly vertebrae due to altered vertebral formation. Ocular findings include posterior embryotoxin from anterior chamber dysgenesis, and characteristic facial features result from altered craniofacial development. A 6-month-old infant presents with persistent jaundice since birth, a systolic heart murmur, and distinctive facial features, including a prominent forehead and triangular face. Which of the following is not considered among the 5 major clinical manifestations of Alagille syndrome? Option A, cholestasis. Option B, cardiac anomalies. Option C, renal anomalies. Option D, vertebral anomalies. Consider the classic diagnostic criteria for Alagille syndrome and which manifestations are considered major versus minor features. The correct answer is C, renal anomalies. Although renal anomalies occur in approximately 40% of patients with Alagille syndrome, they are not among the 5 major clinical manifestations used for diagnostic criteria. The 5 major clinical manifestations are cholestasis, cardiac defects, skeletal abnormalities, ocular abnormalities, and distinctive facial features. Classic diagnostic criteria require the presence of 3 of these 5 major features, or hepatic involvement, plus a confirmed JAG1 or Notch2 mutation. Renal involvement, while common, is considered a minor feature in the diagnostic criteria. A 2-year-old child with confirmed cholestasis presents to your clinic for evaluation. On examination, you note distinct facial features that raise suspicion for Alagille syndrome. Which facial feature is not typically associated with Alagille syndrome? Option A, prominent forehead. Option B, triangular face. Option C, deep-set eyes. Option D, low-set ears. Consider the characteristic facies seen in Alagille syndrome and which features are most commonly described in the literature. The correct answer is D, low-set ears. Low-set ears are not typically associated with Alagille syndrome and may suggest other genetic syndromes. The characteristic facial features of Alagille syndrome include a prominent forehead, triangular facial shape, small pointed chin, and deep-set eyes with upward slanting. These features are present in approximately 95% of patients and tend to become more pronounced with age. While they may be subtle in newborns, they serve as an important diagnostic clue, especially when combined with other manifestations of the syndrome. A 4-month-old infant presents with prolonged jaundice, intense pruritus, and palpable hepatomegaly. Laboratory studies show elevated direct bilirubin and bile acids. What is the characteristic liver histology finding in Alagille syndrome? Option A, paucity of interlobular bile ducts. Option B, giant cell hepatitis. Option C, biliary atresia. Option C, periportal fibrosis. Consider the pathognomonic histological feature that distinguishes Alagille syndrome from other causes of neonatal cholestasis. The correct answer is A, paucity of interlobular bile ducts. The pathognomonic histologic finding in Alagille syndrome is a bile duct to portal tract ratio less than 0.5, indicating paucity of interlobular bile ducts. While giant cell hepatitis may be seen in some cases, it is not specific to Alagille syndrome. Biliary atresia is a separate condition characterized by complete absence of extrahepatic bile ducts. Periportal fibrosis may develop in advanced disease, but is not the characteristic finding. Clinical manifestations include prolonged neonatal jaundice, intense pruritus, xanthomas due to hypercholesterolemia, and hepatomegaly. Progressive liver disease occurs in 15 to 20% of patients. Hepatic management in Alagille syndrome requires a comprehensive approach. Medical management includes ursodeoxycholic acid to improve bile flow, cholestyramine to bind bile acids, rifampin for refractory pruritus, and fat-soluble vitamin supplementation. Nutritional support is crucial, with medium-chain triglyceride-enriched formula bypassing bile-dependent fat absorption, high-calorie diets to address increased requirements, and aggressive fat-soluble vitamin replacement. Surgical options include partial external biliary diversion for refractory pruritus and liver transplantation for end-stage disease. A stepwise approach to pruritus management is recommended, with transplantation indicated for end-stage liver disease, intractable pruritus, growth failure despite support, or hepatocellular carcinoma. During a routine well-child examination, a 1-year-old with suspected Alagille syndrome is found to have a systolic ejection murmur best heard at the upper left sternal border, which is the most common cardiac anomaly in Alagille syndrome. Option A, pulmonary stenosis. Option B, tetralogy of Fallot. Option C, ventricular septal defect. Option D, atrial septal defect. Consider the frequency of different cardiac anomalies in Alagille syndrome and which one is considered the hallmark cardiac finding. The correct answer is A, pulmonary stenosis. Pulmonary stenosis is present in 60 to 70% of patients with Alagille syndrome and is considered the hallmark cardiac finding. Peripheral pulmonary stenosis is particularly characteristic. Tetralogy of Fallot occurs in 7 to 16% of cases, while ventricular septal defect and atrial septal defect are less common. Cardiac involvement in Alagille syndrome typically presents as a systolic ejection murmur best heard at the upper left sternal border. Cardiac disease is a significant contributor to mortality in these patients, and complex congenital heart disease is associated with poorer prognosis. All patients with Alagille syndrome require cardiology evaluation and follow-up, with some needing surgical intervention for severe cardiac lesions. A 3-year-old child with genetically confirmed Alagille syndrome is referred to ophthalmology for baseline evaluation as part of multidisciplinary care. Which ocular finding is pathognomonic for Alagille syndrome? Option A, posterior embryotoxin. Option B, retinal pigmentary changes. Option C, optic nerve drusen. Option D, strabismus. Consider which ocular finding is most characteristic of Alagille syndrome and its diagnostic significance. The correct answer is A, posterior embryotoxin. Posterior embryotoxin is present in 78 to 89% of patients with Alagille syndrome and represents a prominent, anteriorly displaced Schwab's line. It is detected on slit lamp examination and is considered the most characteristic ocular finding of the syndrome. However, it is not entirely specific as it can also be found in 8 to 15% of the general population. Retinal pigmentary changes, optic nerve drusen, and strabismus are not specific to Alagille syndrome and may be seen in various other conditions. Additional ocular findings that may occur in Alagille syndrome include Axenfeld-Rieger anomaly and iris abnormalities. The diagnosis requires correlation with other clinical features. A 5-year-old child with Alagille syndrome undergoes skeletal survey as part of routine evaluation for multi-system involvement. Which vertebral anomaly is characteristic of Alagille syndrome? Option A, butterfly vertebrae. Option B, vertebral fusion. Option C, spina bifida. Option D, scoliosis. Consider which skeletal finding is most specifically associated with Alagille syndrome and its pathophysiological basis. The correct answer is A, butterfly vertebrae. Butterfly vertebrae are present in 33 to 87% of patients with Alagille syndrome and result from failure of fusion of the anterior arch during vertebral development. They appear as a sagittal cleft in the vertebral body on lateral radiographs, creating a butterfly-like appearance. Although usually asymptomatic and most commonly found in the thoracic spine, they serve as an important diagnostic clue. Vertebral fusion is more characteristic of Klippel-Feil syndrome. Spina bifida is not associated with Alagille syndrome, and scoliosis may occur but is not specific to the condition. Additional skeletal findings in Alagille syndrome may include rib anomalies and shortened fingers. A 2-month-old infant presents with cholestasis, a heart murmur, and characteristic triangular facial features. The pediatrician suspects Alagille syndrome and considers initial diagnostic testing. Which initial diagnostic test should be ordered? Option A, liver biopsy. Option B, JAG1 genetic testing. Option C, HITA scan. Option D, complete biochemical liver profile. Consider the logical sequence of diagnostic evaluation for a suspected case of Alagille syndrome and which test would provide the most immediate and useful information. The correct answer is D, complete biochemical liver profile. The initial approach should include liver biochemistry to assess the severity of cholestasis and establish baseline values for monitoring. This test is quick, non-invasive, and provides essential information for guiding further management. Liver biopsy, while showing characteristic paucity of bile ducts, is invasive and may not be necessary initially. Genetic testing for JAG1 mutations is confirmatory but expensive and results take time, so it should not delay initial evaluation. HITA scan has limited specificity and is typically reserved for cases where biliary atresia needs to be ruled out. After biochemical assessment, the diagnostic approach should proceed with organ-specific evaluations including echocardiogram, ophthalmologic examination, and skeletal survey to identify the major diagnostic criteria. The diagnostic algorithm for Alagille syndrome begins with clinical suspicion based on cholestasis in infancy, characteristic facies, heart murmur, or family history. Initial testing includes liver biochemistry, echocardiogram, slit lamp examination, skeletal survey, and abdominal ultrasound to evaluate for the major diagnostic features. Confirmatory testing involves JAG1 sequencing and deletion or duplication analysis, with Notch 2 testing if JAG1 is negative. Liver biopsy may be needed in certain cases. Clinical diagnosis requires 3 of 5 major features or hepatic involvement, plus a confirmed JAG1 or Notch 2 mutation. Important differential diagnoses include biliary atresia, progressive familial intrahepatic cholestasis, and arthrogryposis renal dysfunction cholestasis syndrome. A 6-month-old infant with suspected Alagille syndrome undergoes hepatobiliary scintigraphy, HITA scan, as part of the diagnostic workup for cholestasis. What is the typical finding on HITA scan in Alagille syndrome? Option A, poor hepatic extraction. Option B, delayed gallbladder visualization. Option C, biliary obstruction. Option D, normal biliary excretion. Consider the pattern of hepatobiliary function in Alagille syndrome and how it differs from other causes of neonatal cholestasis, particularly biliary atresia. The correct answer is A, poor hepatic extraction. Poor hepatic extraction on HITA scan reflects impaired hepatobiliary function and is the typical finding in Alagille syndrome. This pattern differs from biliary atresia, which shows non-visualization of the gallbladder and bowel, requiring urgent surgical intervention. In Alagille syndrome, the HITA scan typically demonstrates poor hepatic extraction of the tracer, delayed biliary excretion, but usually shows gallbladder visualization, reflecting impaired hepatocyte function rather than complete obstruction. This finding helps differentiate Alagille syndrome from biliary atresia and neonatal hepatitis. However, HITA scan has limited specificity and should be interpreted in conjunction with other clinical and laboratory findings as part of a comprehensive diagnostic approach. A 10-month-old infant with Alagille syndrome presents with growth failure and laboratory confirmation of fat-soluble vitamin deficiencies despite standard infant formula feeding. Which formula modification is most appropriate? Option A, MCT-enriched formula. Option B, standard infant formula. Option C, amino acid-based formula. Option D, lactose-free formula. Consider the pathophysiology of fat malabsorption and cholestatic liver disease and which type of formula would best address this specific issue. The correct answer is A, MCT-enriched formula. Medium-chain triglycerides bypass bile-dependent fat absorption and are directly absorbed into the portal circulation, making them ideal for patients with cholestatic liver disease like Alagille syndrome. This approach can improve fat absorption by 30 to 50% and is essential for adequate growth. Standard infant formula contains long-chain triglycerides that require bile salts for absorption, which is impaired in cholestasis. Amino acid-based formulas are designed for protein allergy, not fat malabsorption. Lactose-free formulas address lactose intolerance, which is not the primary issue in Alagille syndrome. Fat-soluble vitamins A, D, E, K should be supplemented at 2 to 4 times the normal dosage, with regular monitoring of serum levels to prevent deficiency or toxicity. Nutritional support in Alagille syndrome requires careful monitoring and supplementation of fat-soluble vitamins. Vitamin A should be monitored with retinol levels and supplemented at 5,000 to 10,000 international units daily, with awareness of potential hepatotoxicity and pseudotumor cerebri. Vitamin D monitoring includes 25-hydroxy vitamin D and parathyroid hormone levels, with supplementation at 800 to 2,000 international units daily, watching for hypercalcemia and nephrocalcinosis. Vitamin E levels should be checked with alpha-tocopherol, supplementing at 50 to 200 international units daily, monitoring for bleeding tendency. Vitamin K is monitored with prothrombin time, international normalized ratio, and partial thromboplastin time, supplemented at 1 to 5 milligrams weekly or 2.5 milligrams daily. Growth monitoring should include monthly measurements plotted on Alagille-specific growth curves, with caloric requirements at 125 to 150% of standard. A dietitian plays a crucial role in regular assessments, individualized meal planning, vitamin dosage adjustments, and feeding tube management when needed. A 4-year-old child with Alagille syndrome has severe pruritus that significantly impacts quality of life despite adequate dosing of ursodeoxycholic acid. Which medication should be added next? Option A, rifampin. Option B, prednisolone. Option C, azathioprine. Option D, methotrexate. Consider the stepwise approach to managing pruritus in cholestatic liver disease and which medication has the best evidence for efficacy in this specific situation. The correct answer is A, rifampin. Rifampin has antipruritic effects through pregnane X receptor activation and alteration of bile acid metabolism, making it the appropriate second-line therapy for pruritus in Alagille syndrome after ursodeoxycholic acid failure. The typical dosing is 5 to 10 milligrams per kilogram per day, with response usually seen within 1 to 2 weeks. Prednisolone is not effective for cholestatic pruritus. Azathioprine is an immunosuppressant not indicated for pruritus management. Methotrexate is used for autoimmune liver disease, but not for pruritus in Alagille syndrome. The stepwise approach to pruritus management begins with ursodeoxycholic acid as first line, followed by rifampin as second line, then cholestyramine as third line, and finally naltrexone as fourth line. It is important to monitor for drug interactions and potential hepatotoxicity when using rifampin. The medical management algorithm for cholestasis and pruritus in Alagille syndrome follows a stepwise approach. First-line therapy includes ursodeoxycholic acid at 15 to 20 milligrams per kilogram per day, medium-chain triglyceride-enriched formula, fat-soluble vitamin supplementation, and skincare with emollients. Second-line therapy involves rifampin at 5 to 10 milligrams per kilogram per day, cholestyramine at 0.25 to 0.5 grams per kilogram per day, antihistamines for sleep, and ultraviolet B phototherapy. Third-line therapy includes naltrexone at 0.1 to 0.2 milligrams per kilogram per day, sertraline at 25 to 50 milligrams per day, partial external biliary diversion, and liver transplantation evaluation. Novel therapies in development include ileobal acid transporter inhibitors like maralixibat and odevixibat, farnesoid X receptor agonists such as obeticholic acid, and peroxisome proliferator activated receptor alpha agonists like clofibrate. Management of complications includes hypercholesterolemia treated with statins and bile acid sequestrants, severe xanthomas managed with plasmapheresis, and osteoporosis addressed with calcium, vitamin D, and bisphosphonates. A 7-year-old child with Alagille syndrome has developed decompensated liver disease with ascites, coagulopathy, and worsening synthetic function, which is not an indication for liver transplantation in Alagille syndrome. Option A, portal hypertension. Option B, growth failure despite nutritional support. Option C, mild pruritus. Option D, synthetic dysfunction. Consider the established indications for liver transplantation in Alagille syndrome and which condition would not typically warrant this major intervention. The correct answer is C, mild pruritus. Mild pruritus alone is not an indication for liver transplantation and should be managed with medical therapy first. Valid indications for liver transplantation in Alagille syndrome include portal hypertension with complications such as variceal bleeding or ascites, growth failure despite maximal nutritional support, synthetic dysfunction manifested as coagulopathy or hypoalbuminemia, intractable pruritus that is severe and impacts quality of life, and hepatocellular carcinoma, which is a rare but serious complication. 15 to 20% of patients with Alagille syndrome eventually require liver transplantation. Outcomes are excellent in specialized centers, with 5-year survival rates exceeding 90%. Transplantation typically results in resolution of pruritus and xanthomas, along with improved growth and nutritional status. It is important to note that only severe, intractable pruritus that significantly impacts quality of life despite maximal medical therapy is considered an indication for transplantation. Alagille syndrome requires a comprehensive multidisciplinary team approach for optimal management. Core team members include a hepatologist for liver disease management, a cardiologist for cardiac anomaly management, a geneticist for diagnosis and counseling, a dietitian for nutritional support, and an ophthalmologist for eye examinations. Care coordination is essential and involves regular multidisciplinary clinics, shared electronic health records, a care coordinator for families, standardized surveillance protocols, and transition planning to adult care. Support resources include family support through patient advocacy groups, psychosocial support with mental health services, and educational assistance with school accommodations. This team-based approach ensures comprehensive care addressing all aspects of this complex multi-system disorder. Parents of a newly diagnosed infant with Alagille syndrome ask about the long-term prognosis and factors that might affect their child's outcome. Which factor is most strongly associated with poor long-term outcome? Option A, severe cardiac disease. Option B, posterior embryotoxin. Option C, butterfly vertebrae. Option D, facial features. Consider the major determinants of prognosis in Alagille syndrome and which clinical feature has the greatest impact on survival and long-term outcomes. The correct answer is A, severe cardiac disease. Cardiac disease and complex congenital heart disease are major causes of early mortality in Alagille syndrome and represent the strongest predictor of poor outcome. Other prognostic factors include progressive liver disease, which requires transplantation in 15 to 20% of patients, growth failure indicating severe disease, and the type of JAG1 mutation, with protein truncating mutations associated with worse outcomes. The overall 20-year survival rate is approximately 75%, with 50% of patients having stable liver disease long-term. Cardiac disease remains the major cause of early mortality, while outcomes have improved with multidisciplinary care approaches. It is important to note that while posterior embryotoxin, butterfly vertebrae, and facial features are important for diagnosis, they do not significantly impact prognosis and should not be used to predict long-term outcomes. Long-term management of Alagille syndrome requires systematic surveillance across multiple organ systems. Liver surveillance should occur every 3 to 6 months, monitoring liver function tests, bilirubin, albumin, international normalized ratio, and performing ultrasound, with adult concerns including portal hypertension and hepatocellular carcinoma. Cardiac surveillance should be annual with echocardiogram, electrocardiogram, and blood pressure monitoring, watching for valvular disease and hypertension in adulthood. Renal surveillance annually includes creatinine, urinalysis, and blood pressure, with concerns about renal dysfunction and stones. Vascular surveillance as needed based on symptoms and physical examination, with adult concerns including intracranial aneurysms and bleeding. Nutritional surveillance every 6 months includes vitamin levels and growth parameters, with metabolic bone disease as an adult concern. Quality of life considerations include addressing chronic pruritus that impacts daily activities, potential effects on school performance, social development support, and mental health screening. Transition to adult care should begin in early adolescence, with identification of adult providers, transfer of comprehensive medical summary, and ensuring communication between teams. Vascular complications, including intracranial aneurysms, occur in approximately 15% of patients and require consideration of baseline magnetic resonance angiography in adolescents. In conclusion, Alagille syndrome is a complex multi-system disorder requiring coordinated multidisciplinary care involving hepatology, cardiology, genetics, nutrition, and ophthalmology. Early recognition of characteristic features including facial appearance, cardiac murmur, and cholestasis facilitates timely diagnosis. Management should be tailored to specific organ involvement with stepwise therapeutic approaches. With comprehensive care and the development of novel therapies, long-term prognosis continues to improve. Thank you for watching this comprehensive clinical review on Alagille syndrome. Please follow Pediatric Case Review for more informative presentations, and feel free to comment with any questions you may have about this topic or suggestions for future content.